and the Ballard Spar's webinar on healthcare reform, What Lawyers Need to Know. My name is Brian Pinheiro, and I'm the head of our Employee Benefits and Executive Compensation Group. I'm joined today by Gene Hemphill, the head of our healthcare group, and John Calpas, who's a member of both groups. We have a full-hour plan, so we may not be able to get to all of the questions during the webinar. However, we encourage you to ask questions, and if you send them to us, we'll get back to you after the webinar. If you can email them to these email addresses. For this hour, we're going to try to boil down over 2,000 pages of statutory text on healthcare reform into a small set of important takeaways for our employer audience. Actually, only about a third of the law relates directly to employers. The bulk text relates to changes in Medicare and the extent to which states will receive funding for healthcare programs. We're going to focus on healthcare reform from the employer's point of view. There will be significant changes for employers, employer-sponsored health plans, employees, and retirees. Our goal is to explain what those changes are and when they will come into play. Before I dive into the new law, let's step back and recall the reasons that healthcare reform came about. As the political debate over the past year has shown, there are many constituents and many divergent interests in the U.S. healthcare system. While they have agreed on how to fix our healthcare problems, they all basically agreed that there are three problems that do exist. A large portion of the population has no health insurance, health costs are spiraling out of control, and if we reform healthcare, we need to find a means to pay for it. Now, this gives you a better idea about how Americans obtain health insurance. The healthcare reform effort focused on column 4, 46 million Americans who are uninsured. As a result of the new law, virtually all of those individuals will have access to health coverage. Now, I'll turn it over to Gene and Jonathan in a moment so that we can begin to drill down on how employers will specifically be affected by healthcare reform. But by introduction, let's look at it from 50,000 feet. The healthcare reform law is actually two laws. Patient Protection and Affordable Care Act, which President Obama signed into law on Tuesday, March 23rd, and the Healthcare and Education Reconciliation Act of 2010, which was passed by Congress on Thursday night and is expected to be signed by the President early this week. I have the next 2 days to properly explain the tortured legislative process that led to there being two bills, but suffice to say for our purposes that the second bill makes some relatively modest changes to the first. So the healthcare reform law do? Well, basically, it requires every individual to either enroll in some sort of basic health care coverage or pay a penalty. And can obtain coverage on their own, through an employer, or through a government program, and find that most of the barriers that once existed to access coverage have been removed. Employers, or at least large employers, must play, meaning have to provide basic health coverage to their employees or pay a penalty. And healthcare reform law creates a dizzying array of subsidies to assist small businesses in providing employer-based coverage and to assist low-income individuals in obtaining the coverage. And with that, I will turn things over to Gene to discuss employer options.
Brian, at this point in our program, we want to take employers through their options, both now and once the exchanges begin to operate as of 2014. Each option brings with it certain conditions and requirements. During the transitional period, that is from the enactment on March 23, 2010, until January 1, 2014, the employer can continue its current coverage options. It can do so either as a grandfathered plan or if an employer wants to change its coverage through the employer group health plan market, either insured or self-funded. You can also elect to discontinue coverage or continue to not offer coverage, if that is the case, until January 2014, and no penalties will be incurred under the Act. After January 1, 2014, the options continue, but additional options may become available under the exchanges. Depending on the size of the employer and state, they may have the option to offer a particular level of exchange plan or provide exchange plan support, funds to allow the employees to buy exchange coverage. As President Obama has repeatedly said, if you like your coverage, you can keep it. That is true as long as the employer is willing to continue to offer the coverage to employees. That is the plan that they like. The law says that nothing in the Act shall be construed to require an individual terminate coverage under a group health plan or health insurance coverage if such individual was enrolled on March 23, 2010. The law does not require an employer to continue the coverage, however. If an employer wants to continue its current plan, it can do so by offering it as a grandfathered plan. There are certain conditions and requirements for such plans, however. Let's look at the definition of a grandfathered plan. It is a group health plan or individual insurance coverage for which an individual was enrolled on the date of enactment. It is important to understand the conditions in order to maintain your status as a grandfathered plan. The law states that additional family members may be enrolled if family coverage is included in the plan as of March 23, 2010. All new employees and these may enroll. What leaves uncertain is you can allow existing employees to join your grandfathered plan. For example, it's clear whether you can amend a grandfathered plan after the date of enactment to coverage to domestic partners of employees. With guidance, it may be a problem under the law as written. Grandfathered plans, other than collective bargaining plans, which I will discuss momentarily, will meet certain requirements of the plan as of the plan year following 6 months from enactment of the new law. For most plans that have a calendar year, this means that they must meet these requirements as of January 1, 2011. These provisions include some, but not all, of what have been referred to as the immediate coverage improvements. Requirements that apply to grandfathered plans include 1, that the grandfathered health plan cannot impose pre-existing condition requirements for children under 19 years of age. 2, a grandfathered plan cannot have dollar value limits on lifetime benefits. Also restrictions on annual benefit limits. For years prior to 2014, grandfathered plan may only establish a restricted annual limit dollar value of benefits with respect to benefits that are essential health benefits as determined by the Secretary. The Secretary shall ensure that access to needed services is made available with a minimal impact on premiums. What that means remains to be heard from HHS. A grandfathered health plan may impose annual limits on covered benefits that are not essential to the extent permitted under federal or state law. A grandfathered health plan must extend benefits to children up to age 26. The plan must provide a uniform benefit summary to its applicants and enrollees. In a waiting period in excess of 90 days, it must rescind coverage other for fraud. Other early coverage and market reforms that apply to group health plans that are not grandfathered plans. We will review them shortly. Employers and benefit specialists in the audience, I'd like to take a moment to explain the interaction of ERISA, the Internal Revenue Code, and the Public Health Service Act, PSA, under the new law. Provisions that apply the immediate coverage improvements that we were beginning to discuss and the market reforms that begin in 2014 are amendments to the PHSA. ERISA covers employee-based plans, self-funded and insured, other than certain governmental and church plans. The Internal Revenue Code has provisions that may apply to ERISA plans and apply to government plans and church plans. The PHSA, up until this act, has generally been used to apply federal benefit mandates to insurers providing group health plans, to non-federal government plans, and to church plans. The law applies the PHSA amendments in Subtitle A, that is the immediate coverage improvements that we're discussing, health plans and insurers as is included in the code or ERISA. In other words, the PHSA amendments are incorporated by reference into code and ERISA. If code or ERISA provision conflicts provision of the PHSA relating to group health plans, self-funded or insured, in PHSA will govern. In the Act, there are PHSA provisions relating to discrimination based on salary and rebates by insurers that actually do not apply to self-funded plans. However, to the extent there are existing code provisions on those subjects, they will continue to apply to those self-funded plans. So some of those Title A immediate improvements that we've discussed apply to grandfathered health plans. First, this is one that many people have already read and been concerned about, is dependent care coverage. The particulars that apply both to grandfather plans and all other group health plans. The first year after September 23rd, 2010, grandfather plan must make coverage available to children of employees up to age 26 years of age. This coverage can no longer be based on the child's status as a student or their marital status. Internal Revenue Code, Sections 105 and 162 are amended by the new law to allow exclusion from gross income or a self-employed worker a deduction for the value of the coverage of any child of the taxpayer who at the end of the taxable year has not attained age 27. These provisions were effective as of March 23, 2010. Section 5 is amended to add language to permit coverage under an employee-based plan for a child who has not attained age 27 and does require the child to be a dependent. Does not require the child to be dependent. Thus, the law requires coverage until the child turns age 26, but tax advantage coverage by an employer-based plan until age 27. Until January 1, 2014, the coverage is only available to children who are not eligible for other employer-based coverage other than the grandfathered plan. Requirement for all group health plans, including grandfathered plans, prior to 2014, is provision of a uniform benefits and coverage summary to all plan applicants, enrollees, and policyholders. The law provides that the summary must be culturally and linguistically appropriate. Thus, the employer may have to offer language in addition to English if employees who would require it, and it would be culturally and linguistically appropriate. This does not exceed 4 pages in length, and the print may not be smaller than 12-point font. It must be understandable to the average enrollee, and can be distributed in paper or electronically. If you material modifications to your benefits plan, new notice must be provided within 60 days. There is a fine for a willful failure to follow this requirement of $1,000 per failure, and enrollee is a separate offense. Talk for a moment about collectively bargained agreement plans. Collectively bargained plans have a provision in the law in the grandfather section. It's different from the grandfathered health plan requirement health plans that were ratified prior to the enactment date, March 23, 2010, continue until the last of the collective bargaining agreements relating to the coverage terminates. Although BAs, or collective bargaining agreements, can be grandfather plans, they are subject to the grandfather plans, the requirements that I just summarized. If a collectively bargained plan elects to amend its coverage to conform to those requirements under the Act, it will not be treated as a termination of the collective bargaining agreement for purposes of this grandfathered eligibility status. The question, however, other plan amendments changing the benefits constitute a termination of the CBA. Again, we'll have to wait for more guidance on the answer to that question. So in the beginning, one of your options is to have a grandfathered health plan. But your other option is, if you can't meet some of the requirements, or if you want to start a new plan, would be a non-grandfathered plan. It will offer a self-funded or insured group health plan. In addition to the grandfathered plan prohibitions on existing condition limitations, lifetime annual limits, excessive waiting time, and rescission, and the depending communication requirements, the group plan will also be subject to additional immediate coverage and reporting requirements. It appears that the effective date of some of these provisions to the plans, other than a grandfathered health plan, may be 2014 rather than the first plan year after September 23rd, 2010. Those provisions found in Subtitle C, which is the provision that relates to the market reforms, which are effective until 2014, would not be effective for regular group health plans until that date. Exception in the Reconciliation Act for pre-existing condition requirements, which would be effective for children under age 19 as of the first plan year 6 months after enactment for group health plans. For non-grandfathered plans, this may involve the application of the guarantee renewability and the waiting period provisions, therefore. 14th, benefits plans must also meet the essential benefit and other requirements to avoid paying the employer pay provisions, which we will discuss in a minute. The additional coverage requirements for group health plans that are not grandfathered plans include certain preventive health benefits without imposition of cost-bearing responsibilities on the employee. The group health plans have an appeal process that meets the law's requirements. The group plan will be required to report annually to the Secretary about the plan's quality initiatives. Finally, an insured plan must account for their claims and non-claim costs and rebate to enrollees a percentage of the premium if non-claims costs are too high. Let's look at particulars of these new requirements. Again, repeat, a grandfathered health plan is not subject to these preventative discrimination based on salary, quality reports, rebates of premiums, and appeals process requirements. With preventative health benefits, the group health plan, self-funded or insured, must offer the following preventive health services with cost-sharing requirements. By cost requirements, I mean deductibles, co-pays, and other responsibilities on the plan member. Preventive health requirements are the evidence-based services from categories A and B of the U.S. Preventative Services and tests. These immunizations, pediatric screenings, breast cancer screening, mammography, and other women's health prevention measures. By the way, the law specifically states that for women's health services, and does not have to follow the Preventative Service Task Force recommendations issued in November 2009. Those were the controversial annual mammogram screening recommendations. requirements are effective for the first year after September 23, 2010. Requirement relates to appeals process. With respect to appeals processes, the group health plan must implement an effective appeal process, and the law defines what that means. If the group plan has an established ERISA appeals process under the DOL regulations, it will be able to continue that process, but add an external review process if it does not have one already. The external review process can either comport with a state law requirement if one exists, or minimum the NAIC, the National Association of Insurance Commissioners, minimum standards. The external review process will be a binding process. This requirement is effective for the first plan year after September 23, 2010. The requirement when a claim denied that there must be a notice of appeal process, and that notice must include the availability of certain assistance that might be available in the state for the enrollee in the way of representation or other assistance. Another requirement for group health plans, not grandfather plans, reports to the Secretary of Health and Human Services with respect to the plan, benefits, and reimbursement structures that improve the quality of care covered by the plan. The steps that will need to be covered include what steps the plan is taking to improve health outcomes, reduce hospital readmissions, improve patient safety, and reduce medical errors, for example, the so-called never events, to health and wellness. Annual reports begin after the Secretary releases guidance, and the Secretary is required to release such guidance within 24 months of the date of enactment. For insured group health plans, there's another reporting requirement to the Secretary of Health and Human Service. This requirement begins in 2011 and ends in 2013. You must report on the total premium revenue expended for clinical services to enrollees, health improvement activities, and non-claims cost. If the amount expended by the insurer for clinical services and health improvement activities do not equal 85% of the revenues of a large employer-based plan premium, or 8% of a smaller individual insurance premium, small group or individual insurance premium, the insurer must rebate part of the premium. If there are additional market reforms, if you could do your employee-based plan, group health plan, that is not a grandfather plan, they are generally effective for plan years after January 2014. Include further prohibitions, discrimination on the basis of health status. Of employers in this section of the law are the exceptions created for health and wellness programs, which we will review. There are premium underwriting limits for insured group health plans. Availability and renewability provisions that were earlier for children 18 become effective for all adults, and there are minimum essential benefit requirements that become effective. These include some restrictions on cost sharing for emergency services received at non-participating hospitals. With health and wellness programs, which we know many of our employers are actively interested in, or have plans and programs already. The includes a safe harbor for such programs that many employers may be pleased to see. It clarifies that a health and wellness program that meets the laws and regulations will not be in violation of the law's prohibition on discrimination on the basis of health status. The harbor includes provisions such as a plan provided discount or rebate of premium or contribution, a waiver of cost sharing, the value benefit not otherwise provided by the plan. and must not exceed 30% of the cost of employee-only premium for participation in the wellness programs. HHS, Labor, and Treasury have the authority under the law to increase that to 50% if they choose to do so. Have the opportunity to attempt to qualify for the reward at least annually. And the reward must be offered to all similarly situated individuals, and there must be a reasonable alternative standard for employees with medical conditions that make satisfaction of the reward criteria difficult. These are to some of the requirements in the current regulations. If you have a program that was in existence prior to enactment that met the current regulatory requirements, it can be grandfathered. HHS will publish regulations defining the types of health and wellness programs that qualify. The Act states that they include, at a minimum, personalized prevention services from a provider, a plan manager, or a wellness and prevention service organization. They would health risk assessments, face-to-face counseling, telephone services, or web-based programs. They should cover smoking, weight management, stress management, physical fitness, nutrition, heart disease prevention, lifestyles, diabetes preventions. Please, there's another provision in the law that states that a health risk assessment cannot ask about guns in the household, and discount or rebate can be reduced or withheld on the basis of an individual's lawful ownership of a firearm or ammunition. This is a Second Amendment protection that is specifically provided in the law. The law provides that grants will be available to small businesses for a period for wellness programs. Businesses for this purpose is less than 100 employees who work 25 hours or greater per week. The Secretary will develop the program criteria, and applications for these grants will be made to HHS. Effective 2014, a health insurer's premium underwriting will be regulated to limit variation in premium rates charged. Limits will apply to the individual and small group markets and the large group market exchange plans. Note on this slide, the limits will be compressed and cannot be on the basis of age more than 3-to-1. Can surcharge for tobacco use, but it is limited to a 1.5-to-1 ratio. The biggest issue that employers will face under the new law is what to do about your employer-based plan beginning in 2014 and thereafter. What impact will the availability of the exchange plans have on the continuation of your employer-based coverage after that time? I will take over at this point to Calpas to explain the exchanges and the major parts of the healthcare reform law that become effective on and after 2014.
Thanks. Over the next few slides, I'm providing a detailed glimpse of what the healthcare landscape will look like starting in 2014. One of the most far-reaching changes is that all Americans, subject to a few exceptions, must have health care coverage that provides for minimum essential coverage. Minimum essential coverage can be obtained through one of several sources. First, employer-sponsored health plans, which includes a grandfathered plan, individual policies, whether they are purchased through an exchange or outside of an exchange. And to make it known, we're going to cover this exchange concept shortly in the future here on some of my slides. And third is government-sponsored programs. If individuals elect not to have minimum essential coverage, they will be penalized by the government. The penalties start off rather small, but escalate rapidly. Starting 2014, the penalty for an adult individual is the greater of $95 or 1% of income, and this will rise to $695 or 2.5% of income in 2016. Penalties are reduced for each uninsured dependent under the age of 18, but the penalty for a family can be 300% of the individual penalty. The dollar penalties are also indexed for inflation starting in 2017. These will be administered by the IRS and paid by individuals through the filing of their yearly income tax return. Form 1040, and the reason individuals will be penalized if they choose not to obtain minimum essential coverage is because without widespread participation, us will continue to have a healthcare system where costs and risks are improperly allocated. The hope is that if all people are covered, there will be good risks to negate bad risks and bring down the cost of coverage over the long term. Now, not all Americans will be subject to penalties for not having minimum essential coverage. There are a few exceptions to this. First, there are individuals who cannot afford coverage. These are people whose required contribution for the lowest cost plan option would be in excess of 8% of household income, and the percentage is adjusted going forward. Second is low-income taxpayers. These individuals who do not need to file a Form 1040 because they don't earn enough money. For 2009, that threshold would be $9,350 for single filers and $8,700 for married filing jointly filers. There are individuals who experience short coverage gaps. These are individuals who are not covered by minimum essential coverage for a continuous period of less than 3 months. And fourth, there are members of Indian tribes. While individuals must enroll in minimum essential coverage or pay a penalty, employers will be subject to what is commonly known as pay or play. The pay or play requirement only applies to large employers, which are employers who employ 50 or more full-time employees. For purpose of pay or play, full-time employees are those employees who work at least 30 hours per week. Under pay or play, large employers could face two types of penalties, depending on whether or not they choose to offer health care coverage to their employees. First, large employers who do not offer coverage and have at least one full-time employee receiving a premium tax credit must pay a penalty of $2,000 per full-time employee. The penalty does allow the employer to exclude the first 30 full-time employees from the calculation. Second, large employers who do offer coverage and have at least one full-time employee receiving a premium tax credit must pay a penalty of the lesser $3,000 per employee receive a premium tax credit or $2,000 per full-time employee. Penalties that are assessed by the government on large employers under pay or play will not be tax deductible. Something to keep in mind for large employers, they will have to determine whether it makes more sense to offer coverage to employees through the existing employer-based system or pay the penalty and let employees get care through an exchange. As I mentioned earlier, I'll discuss this in a few minutes. While employers face a penalty for not offering coverage, small employers, those with less than 50 full-time employees, are exempt penalties for not offering coverage. In fact, small employers will be offered government incentives to offer coverage to employees. The last bullet point I have in this slide is the term vouchers. Vouchers are another way for an employer to avoid penalties assessed under pay or play. Employers that offer minimum essential coverage to employees and pay any portion of healthcare coverage costs must provide vouchers to qualified employees. A qualified employee is an employee whose required contribution for minimum essential coverage through an employer-sponsored plan is between 8% and 98% of household income, who are less than 400% of the federal poverty level, and to participate in a health plan offered by the employer. The recipient of a voucher will then use this voucher to purchase coverage through an exchange. The amount of the voucher will equal the amount the employer would have paid for the employee under an employer-sponsored plan. Vouchers are excluded from an employee's gross income, and as I said earlier, will allow the employer to avoid pay or play penalties. Under the current healthcare system, it is almost prohibitively expensive for small employers to offer healthcare coverage to employees. Health reform attempts to fix this problem by offering incentives to small employers who make non-elective contributions on behalf of each employee who enrolls in a qualified health plan. Starting in 2014, the qualified health plan must be obtained through an exchange. For an tax year beginning before 2014, the contributions could be made to a qualified health plan that offered outside of an exchange. To be eligible for a credit, an employer must make at least a 50% non-elective contribution toward the cost of its employees' health care coverage. Additionally, an employer must pay an average wage of less than $50,000 per year and have no more than 25 full-time equivalent employees. For the purpose of this credit, unlike employer pay or play, full equivalent employees, when calculated on an annual basis, are determined by dividing the total number of hours of service for wages were paid by 2,080. Keep in mind that these figures represent the upper eligibility limits for the credit. The minimum credit amount will only be available to employers that have 10 or fewer full equivalent employees and pay an average wage of less than $25,000 per year. Tax credits for small employers are divided up into two phases. Phase 1 covers 2011 through 2013, while Phase 2 becomes effective in 2014 and continues on thereafter. The difference between the two phases is the percentage of the credit. Phase 1 provides a credit of 35%, Phase 2 provides a credit of 50%. I'll walk through a brief example of this credit to highlight the phase out. I want to assume that we have an eligible small employer with 15 employees. That's $40,000 in healthcare coverage premiums for the 2014 tax year, and satisfies the 50% non-elective contribution threshold. Because the employer has 15 employees, more than what is permitted for the maximum credit, it will lose $6,667 of available credit, and the available credit is $20,000. So that's a substantial reduction right off the bat. The way the number is calculated is by multiplying $20,000, which is half the healthcare contribution, times a fraction, where the numerator subtracts 10 from 15, and the denominator is 15. The same employer pays an average annual wage of $40,000. It will lose another $12,000 of the available credit, calculated by multiplying the $20,000, which again is 50% of the healthcare contribution, fraction, where the numerator subtracts 25,000 from 40,000, and the denominator is 25,000. After the deductions, the employer would be left with a credit of only $1,333, a reduction of $18,667. So as you can see, this credit is truly for very small employers. Before I move on, I just want to note the final point on this slide. The traditional tax credits are irrelevant for tax-exempt entities. Healthcare reform legislation provides tax-exempt entities with FICA credits as opposed to a general tax credit. All right, you've heard me mention the term exchange several times throughout this my presentation. Healthcare reform legislation provides for the creation of the American Health Benefit Exchanges and Small Business Options Program Exchanges. You don't need to worry about those terms. They're commonly referred to as exchanges. And what is exchange? An exchange is a marketplace of health insurance issuers that will offer qualified health plans, which is a term, to individuals and small businesses. The purpose of a qualified health plan is the requirement to cover essential benefits. I will discuss these essential benefits on the next slide. Exchange is designed to provide individuals and small employers with access to affordable health care coverage. Exchange will be operational in all 50 states and the District of Columbia by January 1st, 2014. Each state is responsible for creating its own exchanges, and this will be funded through federal grant money. The goals of an exchange are to enhance consumer choice by allowing people to make apples comparison of available plans and bring down the cost of care for subsets of the population that historically had trouble obtaining affordable coverage by creating single risk pools that are based on community ratings. It will no longer be able to discriminate based on individual experience. The permissible variations in premium rates will be those based on age, tobacco use, structure, and geographical location. There will also be a rating system that evaluates the various plans based on quality and price, an enrollee satisfaction system. The feedback from both of these initiatives, like all other information with respect to the exchanges, will be publicly available through an internet portal. Just as a side note, state required plans provide benefits in addition to the essential benefit mandates under exchange. On the slide, while we're on the topic of the exchange, I just illustrate the types of coverage that will be available through an exchange. Again, all plans offered through an exchange will be qualified plans. There are 4 tiers of plans. You have bronze, silver, gold, and platinum. Each must offer essential benefits. Essential benefits include preventive care, emergency services, hospitalization, maternity and newborn care, mental health and substance abuse, and prescription drug coverage. The main differences in each plan level are in the percentage of covered benefits. A bronze level plan has only to cover 60% of benefit costs, while a platinum level plan has to cover at least 90% of benefit costs. There are limits on out-of-pocket expenses for exchange plans. Out-of-pocket limits are based on the amounts established for a high-deductible health plan, and you set at $5,950 for single coverage and $11,800 for family coverage as adjusted in 2014, will drop $2,000 for single coverage and $4,000 for family coverage in 2015 and thereafter. Individuals who are of modest financial means will be able to receive limits on out-of-pocket costs. Notice the catastrophic category on this chart. This type is available only to individuals who are 30 years of age and younger. It covers essential benefits and 100% benefit costs. However, the plan will not begin to pay benefit costs until the out-of-pocket limits are reached. Subsidies will be available to individuals who receive coverage through an exchange. The subsidies are paid directly to the exchange and are based on the federal poverty level. This shows who would be eligible for a subsidy if the exchange were operational today. The subsidies are available to those who earn up to 400% of the federal poverty level. Many middle-class individuals will be eligible for a subsidy if they purchase coverage through an exchange. A family size of 2 and earn less than $58,280 per year, you will qualify for a subsidy. Family size of 4 and less than $88,200 a year, you too qualify for a subsidy. Now, just remember, this is based on the current year limits and will not go into effect until 2014, so the numbers will be revised upward. My slide here shows some of the subsidies for individuals and exchanges. This provides a little bit more detail. There are 3 types of subsidies that function that function limits. You have premium limits, caution limits, and out-of-pocket spending limits. Individual, to take example, has income of 225% of the federal poverty level, you will only have to pay up to 6.3% to 8.5% of income, depending on the year, toward health care coverage. The limit cost sharing will also be reduced for this individual. Compare this to the limit imposed on an individual who earned 350% of the federal poverty level, subject to a 30% limit. There are also substantial reductions in the out-of-pocket spending limits for individuals of modest means. I'm going to discuss plan design changes, funding issues, and some timelines for changes made under the healthcare reform legislation.
Thanks, Jonathan. Just as a reminder, if you have questions, please submit them through WebEx at the bottom right-hand corner of the screen. Alternatively, you can submit questions to our general email address, questions, plural, @spar.com, or send them to me, Gene, or Jonathan directly. If we do them during the webinar, we will respond after the program. Now turn to some of the other provisions of the healthcare reform law that will have some impact on the design and operation of employer-based health plans. Provisions are consistent with creating access to care, such as those that encourage employers to provide retiree health coverage. Others are simply revenue raisers, such as changes to HSAs and health FSAs. So let's turn to the first item, which receives significant media attention, the so-called Cadillac tax. There is such a thing as too much insurance, and there's a concern that individuals who have this valuable insurance will overutilize healthcare services, driving up the total cost of healthcare. The imposes a tax equal to 40% of the excess benefit. The benefit for this purpose is the value of the coverage in excess of $10,200 for single-only coverage, or $7,500 for family coverage. This tax is payable by the employer if the coverage is self-funded, or the insurance company if the coverage is insured. Of course, if the coverage is insured, you can certainly expect that the insurance company will pass the additional tax on to the employer through higher premiums. One of the significant last-minute changes to the new law was a delay in the effective date of this new tax from 2013 to 2018. Something that has received a lot of media attention relates to the coverage gap in Medicare Part D prescription drug coverage, also known as the donut hole. Those who are familiar with Medicare Part D will recall that under the standard arrangement, individuals only pay 25% co-insurance for annual drug costs after paying a small deductible, up to an initial coverage limit. At that point, then there's a gap in coverage called the hole, where he pays 100% of annual drug costs until he or she reaches the out-of-pocket limit, at which catastrophic coverage kicks in. One of the goals of the new law is to close the Medicare Part D donut hole. How will it do that? Well, in 2010, the federal government will pay a $250 rebate to any individual who has annual drug costs in the donut hole. So, covered under a standard Medicare Part D plan for 2010, and you have annual drug costs in excess of $2,830, which is where the donut hole starts for 2010, you will receive a $250 rebate check no later than March 15th, 2011. Beginning 2011, the law will extend co-insurance through the donut hole. So under the standard arrangement, the individual will not pay 100% of annual drug costs at any level, except the initial deductible. On the flip side, the new law makes a change to Medicare Part D that is a revenue raiser. Employers have established their own prescription drug coverage for retirees, are eligible to receive a retiree drug subsidy, called an RDS payment, from government as a reimbursement for part of the cost. To the extent that an employer receives an RDS payment, the expenses that the payment reimburses will no longer be deductible by the employer. And this change now puts for-profit and tax-exempt organizations on equal footing with respect to the RDS payment. Now, with the retiree theme, there's a new program designed to encourage employers to establish, or at least continue, retiree health coverage. Employers can seek reimbursement from the federal government for 80% of the annual cost of coverage between $15,000 and $90,000 per eligible retiree. An eligible retiree for this purpose is a Medicare retiree who is at least age 55. These, of course, are the folks who tend to be the most expensive individuals to cover in a retiree health plan. An early version of this provision would have required the employer to pass through the reimbursement to retirees directly in the form of rebates or premium holidays. The provision is broader. Employer can use the reimbursement to, quote, lower the cost of the plan. I think this means that the employer can get reimbursed for its costs in providing the retiree health plan. Now, there are two potential drawbacks to this program. First, it's a temporary program. It's only available through 2013. The thought that beginning in 2014, retirees can get coverage through the exchanges. Second, the government only allocated $5 billion to this program. Now, while $5 billion is not exactly loose change, it may be enough to provide full subsidies for every employer-based retiree health program. It's those who apply will get some prorated portion of the subsidy. Then makes some significant changes to health flexible spending accounts, health FSAs, and savings accounts, or HSAs. These changes are pure revenue raisers. In 2013, contributions to health FSAs must be limited to $2,500. Currently, there's no formal health FSA annual limit, although most employers impose an annual limit of $5,000 or less. The limit that's being imposed by the new law is adjusted for inflation in future years. HSA accounts can be used to reimburse medical expenses on a tax-free basis and to reimburse other medical expenses on a taxable basis. If an HSA distribution is made for non-medical purposes before age 65, a 10% excise tax generally applies. Under law beginning in 2011, the excise tax for HSA distributions that are used for non-medical purposes is increased from 10% to 20%. Finally, beginning in 2011, over-the-counter drug costs can no longer be reimbursed from either a health FSA or an HSA. Only prescription drugs and insulin costs are eligible for reimbursement. Now, as mentioned, one of the odd things about this new law is that it amends statutes that benefits professionals are not used to dealing with. Benefit plans generally are governed by ERISA, the Federal Employee Benefits Law, and the Internal Revenue Code. What we've covered so far consists of amendments to the Public Health Service Act. Now, this slide arise from amendments to the Fair Labor Standards Act, or the FLSA. Beginning in 2013, employers subject to the FLSA will need to distribute a notice to employees that discusses the existence of the exchanges, the ability of premium subsidies and cost-sharing reductions in exchange plans, and the employee will be giving up an employer subsidy by enrolling in an exchange plan. Also, in 2014, if a large employer with 200 or more employees has an employer-sponsored health plan, the employer must automatically enroll new employees in one of the available health coverage options. Employees would be given the opportunity to opt out of the coverage and go to an exchange. Employers will need to provide advance notice of the employee's rights. The law closes a tax loophole related to health insurance that has often led to some odd results. If an employer maintains a self-funded health plan, the coverage cannot be provided on a pre-tax basis if the plan discriminates in favor of highly compensated individuals. Highly compensated individuals basically includes the top 25% of employees ranked by compensation. The plan can provide better benefits to high-paid people, but it would have to do so on an after-tax basis. However, if the plan is insured, discriminatory coverage can be provided even on a pre-tax basis. The new law closes this loophole by providing that beginning in 2011, discriminatory coverage must be provided on an after-tax basis, regardless of whether it is self-funded or insured. There's a curious provision buried in the middle of the new law that imposes an administrative fee on both insured and self-funded plans. The fee is modest, it's only $1 per covered life, and it does not apply until the 2012 plan year, but it's something to keep your eye on. So we reached the $900 billion question. Who gets to pay for healthcare reform? It really is everyone involved. We already covered the first couple of items, and the part of the law that we're not covering contains all sorts of revenue raisers imposed on constituencies in the healthcare system. I want to spend a minute addressing the final item, which is the new tax on high-income individuals. If your wages exceed $200,000 or $250,000 if you're married and you file a joint return, there is an increase in the health insurance or HI tax that is part of the FICA tax. Currently, HI tax is 1.45% of all wages. Beginning 2013, the tax will increase to 2.35% for wages in excess of $200,000 or $250,000. The same rules apply to SICA taxes for self-employed individuals. In addition to that, there is a new 3.8% tax on high-income individuals. This tax applies to the lesser of your net investment income or your modified adjusted gross income in excess of $200,000 or $250,000. Basically, this new 3.8% tax only applies if you have income in excess of $200,000 or $250,000 and you have some net investment income. We understand that there's a lot of information to process here. One thing to do is to focus on what's in front of you. What's going to happen in 2010? Well, the significant development is going to be the regulations published by various federal agencies. Just as healthcare reform sucked all of the air out of the room on the legislative front for the past year, we expect the same will happen at the regulatory agencies for the rest of 2010. From your perspective, you should start to consider how this will affect your long-term budgets and collective bargaining strategies. You have a largely low-paid workforce. If so, it may make sense for you to end employer-based health coverage and instead send your employees to an exchange beginning in 2014 where they can qualify for premium subsidies and cost-sharing reductions. You're paying the pay-or-play penalty, but it might make more sense financially than actually providing health coverage. Also, provide retiree health coverage. Consider applying for the reimbursement under the temporary reinsurance program, which is to be up and running by the summer. The first wave of significant changes really starts in 2011. You likely will need to amend your grandfathered plans to take into account the healthcare reform changes that Gene described, including the extension of dependent coverage. Also, you may need to modify your health FSA and HSA programs to eliminate coverage of over-the-counter drugs. In 2013, you're going to be preparing for the new regime of exchange-provided health insurance. The temporary programs will end, and the employer will need to distribute notices about exchange-provided and employer-provided coverage. 2013 is also the year that several revenue raisers kick in, with the non-deductibility of Medicare Part D RDS payments, the health FSA contributions, and new taxes on high-income individuals coming into play. 2014, the exchanges will open and the individual enroll or pay and employer pay or play obligations will apply. Employers, once again, will have to change dependent coverage to cover dependents until age 26, even if they are eligible for other employer coverage. And 14, it is difficult to project in any detail what employers are going to need to worry about. These should be up and running, and you may see some exchanges offer large employers the ability to obtain group health insurance coverage. Cadillac plan tax will become effective in 2018. Brings us to the end of our healthcare reform webinar. We hope that we've been able to give you a better sense of the specific issues facing employers. We will email around the audio recording of this webinar when it becomes available. Also, please check out our dedicated webpage, www.ballardspa.com/healthcarereform, for latest developments on the new law. We'll link directly to the questions that have been submitted. Please contact us if you have further questions, and thank you once again for joining us this afternoon.